Hey everyone, I think we're going to go ahead and get started. So I want to welcome everyone and thank you for taking the time to be here today. We're going to be talking today about the cutting-edge research that's being done at UT Austin to address the issue of dementia. People often want to know, well, what's the newest? What's the most recent? And that's happening here at UT Austin, and we want to tell you what it is. To begin with, I'm going to take a moment, though, to explain the phenomenon. Oh, I need to do a couple housekeeping issues. Just so you know, we're going to do question and answer at the very end. We're going to have 4 talks. That'll be at the very end. We're going to put at the very end some QR codes so that you can sign up for our listservs. And then we will email you all the resources we talk about in our talks. So you don't have to feel rushed and, oh my gosh, I didn't get that down. We'll send it to you. And if we have a Zoom audience, I think, we're going to send it to you as well. So don't worry about that. We are going to need to clear this room at the end because there's another event right afterwards, but we'll all be in the lobby, so we can sort of talk there. Having had started with that, I want to tell you a little bit about the phenomenon we're talking about. What is dementia? Dementia is not actually a disease. You're going to hear us still use that word, but it's actually not. It's a set of symptoms. And those symptoms include what you might expect. There's a decline in memory. That's what we think of. There are problems with language. And I don't mean you don't remember someone's name. I mean that really, really problematic issues in understanding and producing language. There are spatial visual problems. That's our silver alerts, right? You hear the silver alert. Well, somebody's so disoriented, they're driving and they don't know where they are. That's incredibly distressful for them and for their family. I want to make it clear this is not a normal part of aging. We are talking about pathology. We are talking about things that are linked to disease. And it is severe enough to interfere with your daily life. So, did everybody here get some lunch? You following me so far? You're good. That is not dementia. Dementia is, I couldn't figure out where the lunch line was, okay? Dementia is caused by a number of diseases. Alzheimer's is the most common. It's 80% of the cases. And you will hear the term Alzheimer's used interchangeably with dementia. We will even do that today because some of our data are from Alzheimer's disease, but it's not the only type. There is vascular dementia with strokes, there's Lewy body dementia, there's frontal temporal lobe. There are a variety of types or diseases of dementia. So just so that, if nothing else, now you have something from these talks that you can take home. So that's the phenomenon we're talking about. Why are we talking about it here? Well, aging is the future. I mean, that is the best alternative. The other alternative, not as good. Aging is the future. And Texas is the future of aging. We have the 3rd largest population of adults over the age of 65. We're growing at a rapid speed in that regard. We have rural, urban, people who have served in the military, people from a variety of backgrounds. We look like what the United States on the whole is heading towards. Now, in addition, we have a very high rate of dementia. This is a statistic pertaining to Alzheimer's disease. We have actually closer to, over 500,000 people with some form of dementia. That means we have 1.1 million caregivers for older adults with dementia in this state. They are producing 1.9, almost 2 billion hours of unpaid care at a cost to the Texas economy of $33 billion a year. Now that is to say nothing of the emotional toll this is having on their families. This is a major problem. It is an ongoing problem, and it is something that needs to be addressed. We have a research agenda that we're going to go into in more detail today. If we're going to attack this issue, we need to know what the risk and prevention factors are early in life. We've got to do this for our children and grandchildren. We need to know how to prevent it and maintain our cognitive health for those of us who might be sort of in that midlife range. And then we need to develop interventions for the people who already have it. We have a lot of longer-term goals, but we have people right now who are suffering and require empirically tested interventions. Fortunately, UT Austin is very well situated to address all three of these areas, which we're going to talk about today. We are truly interdisciplinary in our research. We have over 100 researchers on campus studying different aspects of cognitive health and dementia from nearly every single unit on this campus. I'm going to just give you a very quick, what I'm going to call popcorn view of some of the research that is cutting edge, that is addressing some of the key issues in this field. To begin with, we have a researcher in the Moody College of Communication who's looking at bilingualism and dementia. Increasingly in the US, we have more and more older adults who are or were bilingual, and there are questions about, does bilingualism protect the brain? Which language goes when you have dementia? We have a very interesting set of researchers in both pharmacy and the Dell Medical School looking at delirium or disorientation in the hospital post-surgery. You may have heard of this, you may have seen this. A relative goes into the hospital and they become very disoriented. There has been some thought that it might be the anesthetic, but we have a researcher who's saying maybe it's the inflammation from the surgery itself. We have a researcher who's tracking as they go about with sensors, what is the pace of that delirium. In other words, we're keeping the brain healthy when the body needs to be in the hospital for some kind of intervention. We have an AI chatbot study. Caregivers need support. They need to be able to talk to someone. Can we get that for them immediately with AI? We have sensors to objectively measure what people are eating, and just so you know, later, a little spoiler alert, you're going to hear about the effects of obesity in risk in midlife. And people are not very good at self-reporting. That little handful of M&Ms that people took as they went through the lobby, not on the self-report. Okay, we have some quick videos for fraud prevention. People in the early stages of dementia or even with mild cognitive impairment are at very high risk of fraud, loss of money. We have efforts to prevent that, educate them. We have study of the loss of child and grief. That is a very sad thing that happens to many people by the time they're in their 80s or 90s, and it affects the brain. Preventing falls with dementia. Okay, I think this is a scenario that you can think of. We know someone who had a fall and it precipitated a long cascade of events that led to death. People with dementia are at very high risk of falling, and it's a very hard thing to prevent. We have efforts on this campus to do that. Down syndrome, an incredibly high risk factor. Sadly, people with Down syndrome are extremely likely to develop dementia as they grow older. An app to evaluate long-term care facilities. This is a really, really cool thing, drawing on Medicare records, Medicaid records, death records. How do you know if this particular nursing facility is going to take good care of your loved one? Well, this one is data-driven. We have someone tracking cognitive performance throughout the day. You may think, oh, they gave me a cognitive test and now they know how I'm doing. But if you think about it, your cognition is not one thing. It comes and goes. There are moments when you think better than other moments. We have someone here tracking that, because if we can identify that, maybe we can enhance brain health. We also have a true gem on this campus that's a compilation of researchers, the Center on Aging and Population Sciences. This center is funded by the National Institutes of Health, National Institute on Aging. That map shows you there are only 12 in the country. Take a look at where we are. We truly stand out. There are a lot of older adults in the South, in the middle of the country, in the Southwest, Northwest, who are not receiving attention, except from us. This center, Deb Umbersam is the director, and we just got our renewal from the National Institutes of Health, where it is, yes, a round of applause for Deb, where the peer reviewers, the National Institutes of Health, I should tell you, we got a perfect score, which is pretty much unheard of. It's pretty much unheard of. It's a credit to Deb in her ability to put together the grant, but a credit to UT Austin and the quality of our research. Because when the National Institutes of Health and the peer reviewers looked, it was almost like if any place is going to get that funding, it has to be UT Austin. So both a point of pride and a point for you to understand, like, we really are on the cutting edge here. We also are extremely active in education. A shout out to our Graduate Student Council, who is very active today and always helping us. They have a lot of events themselves where they get together. They're from all over campus. Very interdisciplinary, very much the future of research, very important to the campus on the whole, because they're the place where someone comes to me and says, hey, did you know that Dr. Munoz's group is using this, and Dr. Duarte is using that? So they're really the heart and the future of what's happening. We have a number of other educational programs, one through the Dell Medical School and social work and nursing, looking to give help to people who are healthcare professionals, online training in working with older adults. Let me see here. Sorry. I wanted to mention that we also have a very important initiative on the ballot right now for Tuesday. And it's part of the reason we wanted to just take an opportunity to share with you and even share with each other what's going on all over campus. Proposition 14 is a constitutional amendment to establish the Dementia Prevention Research Institute of Texas. It will be a $3 billion investment over 10 years to accelerate the kinds of research that we're talking about today to prevent and cure dementia of all types. It's based on the CPRIT model, the Cancer Prevention Research Institute, that produced things like CAR T therapy, immunotherapy. A lot of the cancer therapies you now think of as standard of care, but now Texas is on the map as the place. Stanford Medical School refers people here. We're going to do that with dementia if we end up getting that funding. I do want to comment on the structure of the rest of these talks. We're going to hear next from Chandra Muller, who's going to tell us about the early life risk and prevention factors. How do early life experiences shape later life cognition? This is the legacy we can leave for future generations. We're going to look at prevention. Audrey Duarte will be telling us how to maintain cognitive health and what we know about that. And finally, Benge is going to tell us what can be done for people experiencing dementia now. We have the state-of-the-art intervention and care for people with dementia. I have to express some gratitude to the many sources of funding. We have tremendous support from the University of Texas at Austin, the National Institute on Aging, and St. David's Healthcare to keep our research, or at least our center, growing. Our theme today is turning knowledge into action, and I'm looking forward to hearing from my colleagues who really know how to do that. I'll turn it over to Chandra.
Thank you, Karen. And thank you for coming. I'm Chandra Muller, a professor in sociology at UT, and also the co-director of the EdShare, Education Studies for Healthy Aging Research. Do you need me to be here?
Yeah, because there's 100 people online. So
okay.
If you want to take this off, you can,
yeah.
but you really got to talk into it, or else they won't hear you.
Okay. As a short person, this podium really... I'm curious, how many people here have a family member who has experienced dementia? How about friends? And or friends, family and or friends. Yeah. When I ask this, almost always we see an overwhelming number of hands because dementia touches just about every family. And that's true globally, actually. Here's a graph showing the prevalence of dementia globally. It's the 5th leading cause of death. But there are a couple of other things that are worth noting here. You can see an uptick at around age 50. At around age 50, the prevalence of dementia doubles every 5 years. What do we see here? An exponential growth curve. That means that we're going to be seeing more and more cases of dementia because our population is getting older. Currently, there's no cure, but there is prevention, and there is tremendous evidence that some people hold cognitive reserve, but we don't understand the key to how to unlock that. By 2050, we expect very many people to be living with dementia, and as Karen said, the costs are high, both the hidden costs in terms of family and time that's unpaid, and also, of course, the societal costs. I'll note also, you see a gender gap here in the prevalence of dementia, and that's due almost entirely to the longer lives of women. So differential mortality explains most of that. Okay, so what about the age of diagnosis? People are diagnosed with Alzheimer's disease and related dementia mostly between their 60s and their 80s. But the early symptoms, the first symptoms of the disease, start at least a couple of decades earlier. And it's hard sometimes to recognize those. As I said, the prevention is a key to a lot, and most of the prevention strategies come from modifiable behaviors and other risk factors. Education, hearing loss, smoking, all of these have some sort of preventable fix to them, and often have social roots. That's why people, and disparities, that's why people think that the key to unlocking that cognitive reserve may be in understanding the social roots of dementia risk. People with many indicators of biological, physiological indicators of dementia never develop the dementia. Why? It's often people believe something that's inherent in the social world. What people are focusing on in particular is education, but it may be more than that. My team, though, is focusing on education. I'll just give you a sense. Remember I said it starts early? Well, it starts in early life, and some researchers have traced it back to very early life, the long arm of childhood. Mark Hayward here at UT has talked about that. And it builds. We spend a lot of time in schools. Schools lay the foundation for a lot of what happens later on in the work, family life, and some of the stress-related diseases, cardiovascular and diabetes, have a lot of social roots to them. Also, obviously, physiological component. It's a mix of genes and our social world. And then at midlife, we start to see certain signs, but that's long after some of these roots have been planted. Okay, and then we finally get to ADRD. So what do we need to study this? Well, we need data that covers early life and later life. It needs to cover what's happened in the formal institutions, like schools, like healthcare, that serve people early, and be population representative, because there's no silver bullet, there's no easy fix to this puzzle. So we need to understand both the social pathways and the biological pathways together. Our team has started to do that along with others, but what we focus on is some post-World War World War II initiatives. Both Sputnik and the civil rights movement had a call for improved education in STEM fields for people who weren't typically gaining access to schools to give everybody an equal opportunity to learn. And also at that time, as a function of technology in that time period, the capacity to collect data improved greatly. We build on those two initiatives to leverage two key data sets that came out from that early period. The NLS 72 and the high school and beyond, the high school class of 1972 and the high school classes of 1980 and 82. What we did is go back to those people. Sorry, I'm going to go back to this slide for a moment. Those initial data collections collected extensive data about their education, their skills, their test scores, their grades, what courses they took, and what colleges they went to, and then what jobs they got. We went back as they entered midlife, the later part of midlife, and re-interviewed them. We collected blood, and we're now collecting MRIs on some of them. The research team has 5 principal investigators, myself, 2 people from Columbia, but I want to also highlight a growing investigative team here at UT. Our main EdShare program does not have an institutional home, but here at UT, we're the home to this grant. It's actually the largest of the grants to collect the old data from the oldest people. You can see here we've the ages when there were data collections, when people were interviewed. And it goes from age 16 all the way up to around age 71. So what have we learned? Very quickly, this graph shows cognitive functioning around age 60, and each of those curves shows a curve of educational attainment. So when you have lower levels of educational attainment, you have lower cognitive functioning at midlife. But there are a couple of important things to note here. One is that there's a large area under the curve where there are a lot of people who have differing levels of education, but similar levels of cognitive functioning. We can explain 80% of the differences in cognitive functioning by high school educational indicators that aren't necessarily reflected in their educational attainment. What else do we have? Well, very, very quickly, high school education predicts better jobs, higher wages, not surprising, financial security, better rated, self-rated health, longevity. We now are starting to analyze the biomarkers, and I'm very excited. I am going to tell you my favorite early finding, which came out this summer. We did some long-read sequencing from the genes. It's a new method for analyzing the genome. And the guy who does the work for us said, apparently people are believing that there's a neuroprotective factor in some genetics. And he said, in our high school beyond cohort, there were the most, had the highest count of any cohort he's seen so far. So I think there may be some interesting intersection of those neuroprotectors that are such a high risk and educational social experiences. What are our future priorities? Data collection, developing an infrastructure that goes beyond just each grant, and really getting the word out and improving communication. Thank you.
You did. Hi, everybody. Thank you for coming. I'm Audrey Duarte, and I'm going to tell you a bit today about work that is being done across UT, and this is just a little smidge of it. But looking at these preventable factors, things that we can control in midlife and older age. So the approach that I'm going to tell you about, the researchers I'm going to tell you about in their programs, is really what we would call like a basic science approach. And what we're trying to do, the way we do it, is we invite people from the Austin area community. So they come to us, they participate in research, usually here, sometimes at home, and we do a deep dive on people. So we're really interested in their environments, their neighborhoods, their cognitive abilities, their lifestyle, the physiology, cardiometabolic health, et cetera. And we also do a lot of brain imaging to understand brain activity and integrity. The goals of this kind of approach are to understand the how. So we have ideas about factors that are important. I'm going to tell you about some today, but we need to better understand how they're operating to predict dementia. And the reason that we need to do that is so we can design better, personalized, more successful interventions on a person-by-person basis. So I'm going to tell you about some work. One person I want to mention here is Dr. Allie Clark. She's been recently gathering some amazing data, and this is from Austin area people. So her work has shown that about 30% of older people living in Austin have been living in the same areas that have rising income segregation. And what is the effect of this income segregation? So basically the income in their area has decreased over this 20-year span. People who are living in those areas show a, oh, good, pointer. Oh, that's not working. They show a higher level of Alzheimer's pathology. They also show a lower level of brain thickness. And the region that's most affected is that region that is the first affected by Alzheimer's disease pathology. So this really important work is showing that people living in an area of worsening income segregation, not far from here, a couple miles from here, are more susceptible to Alzheimer's disease pathology and likely dementia. So access to things that come with an income resource-rich neighborhood, like green spaces, healthy groceries, public transit, these are all important factors that can be associated with dementia risk or the lack of them. So Dr. Liz Munoz, she does interesting work with her group measuring through mobile apps people's daily reports of stress or within-day reports of stress. So I think everyone can relate to this. Our levels of stress may fluctuate with the day and may affect our cognition. And so that is the relationship that they're interested in her group. And they're really interested in understanding what is underlying that relationship with a focus on cardiometabolic health. So how many of you are aware of like these glucose monitors that you can you can monitor your glucose all day? They're doing that as well as other things. And this is ongoing work, but they have people with these mobile phones get alerts asking them about their stress reports. They can measure cognition on these phones and their metabolic health, and trying to understand this relationship in people in midlife and older. So the benefit of this approach is you can reach more people because everyone has a cell phone, and you don't necessarily need to come into the lab for that. Another really interesting area of research is Dr. Andriana Haley's work looking at something called visceral fat. So this is fat around organs, in this case the liver. And we know that liver fat is a risk factor for dementia, but we don't know why that is. And this project, which is an intervention study, gives us a little bit of an idea of what's underlying that. So people in this study who were 40 years and older, again, Austin area people, they were given a low-calorie or low-carb diet for just 2 weeks. And people who were on that intervention showed a reduction in their liver fat, here we go, a reduction in brain toxicity, a reduction in neural inflammation, and an increase in this pattern of brain activity measured with MRI that is more youth-like. So just from a 2-week, and these people were not starved. It was a good level of calories, and either diet worked just as well. So this is really amazing. It shows that even short-duration dietary interventions can reduce these factors that are associated with increased risk of Alzheimer's disease. I'll just touch on a little bit of work that we've done in my group, looking at sleep. So we're really, who's interested in sleep in this room? Yep. So sleep worsens as we age. Not the best, but it's true. And that's a normal part of the aging process, unfortunately, I'm sorry to say. But poor sleep is a risk factor for dementia. And what we're interested in is trying to understand, again, why that is. What is the mechanism underlying this connection between sleep and dementia? And so what we do is we invite people to use wearable electronics, watches that monitor their movements during the day, so we can understand if, when they're sleeping, how well they're sleeping. We have wearable electronics that measure brain activity while people are sleeping. And collectively, we can look at these measures of sleep and understand how it's impacting memory performance on an individual basis. And what we found is kind of counter to this idea that because older people may sleep worse, they aren't as negatively impacted. Their cognition is not as negatively impacted. This is an idea in the literature. We didn't show that at all. In fact, we showed that people who have lower sleep stability, more night-to-night variability in their sleep, actually had the worst memory performance, and that was especially true if they were older adults. We have also shown that when people are engaged in a memory task, we have them try to learn new information, that the level of brain activity that supports memory is lowest in people with the lowest sleep stability. So importantly, all of these factors I've mentioned are things that we can intervene upon. So what we've learned, that low, even in Austin, low resource neighborhoods, and this pattern should replicate across other cities as well. Daily stress, visceral body fat, poor quality sleep, these are all risk factors for cognitive impairment, Alzheimer's disease, and worse brain integrity. A lot of the researchers here are following people over time to see, to better understand when people may transition into Alzheimer's disease or dementia. Importantly, as I mentioned, we can control these factors through interventions. And what we're trying to do is better understand on a tailored basis, like a personalized basis, who's going to benefit from these different interventions? Because it's not a one-size-fits-all approach. If it was, then we'd probably all not be worrying about dementia like we are. So we're really trying to understand these relationships in a really heterogeneous population that represents not just Austin, but Texas and the United States. Thank you.
Hello, everybody. My name's Dr. Jared Benge. I'm a clinical neuropsychologist. I'm a clinician first and foremost. A neuropsychologist is somebody who literally sits around and thinks about thinking all day. But I mentioned that I'm a clinician because that is the core of my identity. I'm a clinician first and then a researcher. And my passion is to bring these interventions, bring all of this amazing research that's being brought into real people in the real world. And this is the hope that I think UT Austin has in this age of trying to put a dent into dementia care over time. Our ultimate goal in our laboratory and across the medical school and across campus is to help real people in the real world right now. Right? The need is immense. The need is now. What can we put in the hands of people right now to help? And to be able to do this meaningfully, we have to bring the best minds, the newest ideas, the most innovations in technology. And we have to have a platform for delivering care to the people that need that the most. And so today what I'm going to do is actually review just a handful of the examples of ways that this is happening on campus. I will leave people out. I will leave studies out that are near and dear to me, so I apologize in advance to friends and family who I am not able to shout out today. But the work is happening now. The need is now. So the first thing I want to talk about is our Comprehensive Memory Center at Dell Medical School. This is where I practice. I came to UT in order to practice at the Comprehensive Memory Center. And the way we work in the CMC is that we practice truly interdisciplinary care. This is not a place where you just see a physician. It's a team of individuals consisting of our physicians and physician's assistants, our social work team that cares for the carer. We'll talk a lot about that today. Neuropsychologists, speech language pathologists, our MA and support staff. All of these individuals are involved in our team care. And this team has been responsible for bringing some of the state-of-the-art treatments that many of you have heard about in the news over the last couple of years, where we have the first biological agents that are actually changing the trajectory of the course of Alzheimer's disease. This is a payoff on 45 years of research into the underlying pathophysiology of Alzheimer's disease. We use the term Alzheimer's disease to refer to clinical conditions, but underneath the microscope, this is caused by the accumulation of two proteins, beta amyloid and hyperphosphorylated tau. The latter, hyperphosphorylated tau, is 1 billion points in Scrabble, if you can spell it out. And so for the first time, we have interventions that actually remove amyloid from the brain. And while they're not a cure, they do slow the progression, the rate of progression in individuals who have mild cognitive impairment and mild dementia due to Alzheimer's disease. Our clinic is one of the leaders in this area at bringing these new amyloid-modifying treatments, putting these medications into practice in select patients. On top of this, our clinic is also training the next generation of providers. I look out and see a row of trainees here from our clinic. The need in Texas for specialists in Alzheimer's disease and aging-related disorders is immense. We're about 2,000, depending on who you read, 2,000 to 3,000 providers short of meeting the need for care. How do you meet that need? You have to grow the next generation. I'm very excited to be growing the people that can take my job. Okay. In addition, our approach to care goes beyond diagnosis and goes beyond just biological treatments. We treat people and not proteins, okay? So part of this care model means not just identifying and diagnosing the underlying conditions, and not just applying medications, but working with speech-language pathology to learn cognitive linguistic skills, to learn strategies to adapt to these things. Working with caregiver counseling, working on future planning and connection to community resources. It's hugely important when you're working with conditions as complex as ADRD, Alzheimer's disease, and related dementias, that you care for more than just the medical status. And that's what I'm proud that we do in the CMC. I want to give a deep dive here to the work of Dr. Maya Henry and Stephanie Grasso. If you want to be pumped up after reading a journal article, which is probably something that not many people do, I encourage you to Google Maya Henry and have fun, okay? We think of dementias as affecting primarily memory. People think of them as a memory disorder. But these proteins can accumulate in other areas of the brain, and there are different forms of protein, TDP43, different tau variants. And sometimes I want to gesture desperately at my model brain, but sometimes they accumulate in language parts of the brain first, causing conditions known as primary progressive aphasias, or PPAs. PPAs have been a long overlooked variant of dementia that robs language. And I went back and looked at my notes to see about this. When I was in training, here's what I had written down about PPA. Failed donepezil trials, model for interesting language things. And that was what we knew about PPA. Until Dr. Henry and her colleagues group came along and started pioneering behavioral treatments to bring back language skills in individuals who have PPA. If you ever talk to someone affected by dementia, their primary goals are to maintain their sense of self and not be a burden on their families. These skills help with behavioral treatments to help find the language targets that are most meaningful to patients and caregivers, to learn innovative ways to apply those strategies behaviorally, and increasingly now with biological interventions, electrical interventions on top of this. Leverage telehealth technology so that we can serve people all around the country. And trying to adapt these these treatments to language of origin to bring these treatments around the world. It's truly inspiring work that gives people back their voice. It gives them back their sense of self. And it's an amazing example of what good evidence-based research can do. Part of the reasons that I came to UT Austin is because I study technology and cognition and the intersection between those and aging. And UT is an incredible place to understand how technology is impacting the way we think, the way we experience the world. In our lab, we're doing the battle royale between paper calendars and Google Calendar, all right? Why study something like that? Well, again, we want people to be independent in the real world now, even in the face of memory problems. What tools can we put in people's hands now? What's the right tool for the right person at the right point of their disease to help them maintain independence, to maintain the goals that they want to pursue in themselves? We want to disentangle the impact of technology on cognition as we age. Again, there's concerns about whether the impact of technology may affect our cognition and dementia risk as we age, and through some of the exciting data sets through high school and beyond, we're starting to be able to tease apart these different features and actually understand what the trajectory of, how cognitive trajectories may be altered by exposure to digital technologies. Through the work of Dr. Edson Tomas, being able to look at how smartphones can actually give us real-world passive sensor data that helps us identify the earliest changes and track cognitive decline over time. The future is digital, and the future of dementia care will be digital, and that's one of the many things that we deal with here at UT Austin. Finally, I want to give a shout out to all the work being done on campus to caring for those who care. You know, we talked about Alzheimer's disease and related dementias as these microscopic proteins, but I like to think about them as these pebbles that are thrown into a lake. And you see the ripple effects out here, right? And these microscopic proteins affect not just the person living with the disease, but those that care for them. How do we care for the carer? So Alyssa Geary is here, and she's working on identifying and tailoring the actual, how do we actually measure the individualized needs and goals of caregivers and track responses to intervention? Her team, as well as the team from nursing, are working together to identify evidence-based curricula, actually develop curricula so that everyone who's going through one of the helping profession programs at UT Austin can learn a little bit about how dementia care works. Whether you're a pharmacy trainee, a med student, SLP student, if you're gonna be leaving UT and helping, how can we train you so that you are prepared for the next generation of dementia care? Dr. Benge is working on developing AI treatments so that you can get just-in-time interventions for caregivers at the time that they need advice, that they need help, which tends not to be from 8 to 5, okay? So hopefully that gives you just a taste of the type of dementia care research that's going on at UT Austin. This is work that spans disciplines, departments, and schools, and we truly are a world-class institution that is able to rise to the challenge of helping real people in the real world right now.
Well, I did mention that we would have these QR codes up. If you would like to register to be on our listservs, so you can find out about our future events, so we can send you our resources from today, everything that we've talked about. And also, if you'd like to support our programs, we also have a QR code there. I'd like to start by taking some questions from people in the room, and then we'll move to the Zoom group. We have, I think, a mic. You're going to give them the mic? Okay, go ahead. They have a spare mic. They're going to give that mic to the people in the room.
Okay. I can, hold on. You probably can't spend 5 minutes on TV without looking at some commercial that promotes some supplement for taking people my age particularly, take something and hopefully your memory will be better. Any thoughts on whether it is worth spending a couple $100 a month on that?
Okay, Jared, you work more in the clinic, so just ask our tech people, will these work just directly if we answer? Okay, you can answer into yours.
Thank you for that great question. That's only a question that I get asked on days that end in Y. Happy to answer that one. So at the current time, there have been very few supplements that have gone through the rigorous science that allows us to draw definitive conclusions about their efficacy. The evidence base is pretty weak for a lot of things that are supplements out there. This isn't to say that there won't be work that eventually shows some promise. There's some exciting works with things like vitamin E, Dr. Haley's work on the different nutritional impacts of diet, on inflammatory markers is kind of leading the charge there. So there's insufficient evidence yet to make us, support any given intervention like that. My general advice to people is do the stuff that we know first. Make sure you invest some of that money in a good pair of walking shoes, because we know that's associated 20 to 30 minutes, 3 to 5 times a week is associated with increased hippocampal volume and better memory performance. We know that eating a balanced diet, basically heart health equals brain health. So eating a diet that's good for your heart tends to be good for your head. Socializing, playing games, being mentally active, and then after you've done all those things, if you have time and disposable income, talk to your physicians about what you can try on yourself. But do the things we know first.
Anybody else? I didn't mean to just, okay. Well, let's see if there are other questions from the crowd that people are interested in. Yeah.
Good afternoon. Adriana Perez from the University of Texas Health Science Center at Houston. Thank you for the opportunity to be here and to listen to your presentation. If we are interested in collaborating with you and develop grants and to try to understand what can we do together, what will be the best approach to do so? Thank you.
Yeah, we would very much look forward to it. I should say that this state is well positioned across institutions. There's a lot of exciting work going on, and we look forward to collaborations. We do collaborate, and we have collaborated with a number of the other institutions. We're a very cooperative state, and so we're really in this together. We're going to conquer this disease together. Yeah.
Hi. First of all, thank you for your wonderful talks. And this might be a general question about dementia and dementia caregiving, but I was wondering, from both perspective of the caregivers and person with dementias, I think one of the most confusing and overwhelming stage is the early stage of the recognized dementia symptoms of my family or friends. So sometimes I think people seem to deny or avoid of the symptoms of dementia of my family or friends. So sometimes it can even delay the diagnosis of dementia. So I was wondering, how can we handle this transition period or this early stage of dementias?
You bring up a really good question, is the idea of talking about this issue and how do you communicate as a family with the person and with each other. I don't know if one of you has some thoughts on that, Audrey, or do you have any, how do we, let's start with that. How do you recognize the early signs of it in some of the research you're doing or your colleagues are doing?
Yeah, I can say a little bit about it. I mean, Dr. Benge is really the expert in this area, but yeah, early detection is really important. I mean, everyone agrees on that. And while there are these general symptoms, there's a lot of individual differences in this space too. So for some people, maybe it presents as they go to the store and they come back and didn't get the usual things that they would get at the store, or maybe being even more forgetful than usual, forgetting people's names more so than the typical, or it could be getting lost more often is a common one, or it could be more somatic symptoms like more sleep disturbances, that sort of thing, or mood changes. I'd say probably this would be my, but I'd love to hear what you have to say. Changes in mood might be underappreciated as a potentially early symptom of cognitive decline, but I'd love to hear what Dr. Benge has to say.
I have thoughts, let me break this into two categories, because you brought up two good points. One is the idea of recognition of symptoms, and a term that came up in your question that comes up in my world a lot as well, is this concept of like denial. And I want to push on that just a little bit. Individuals who have memory problems tend to forget what they forgot, right? And so what can sometimes look as that someone is denying having symptoms, it's actually a concept that in our world, because we have to make up language to bill insurance, we call anosognosia, literally to not know that you don't know. All right, and so sometimes the patient themselves is going to be unable to remember what they forgot last week because they forgot last week. And so this puts the onus on the caregiver and on the family to start these conversations. And what I encourage when I'm talking to families about starting this conversation is that, first of all, to recognize that many of these things can be treatable or even reversible. Not all things that forget are actually going to be dementia. There can be things like B12 deficiencies, thyroid problems, all untreated depression, all sorts of things that can manifest as memory changes, or that can be dementia mimics, pseudodementias. And so the first step is to start the conversation with the primary caregiver. A primary caregiver is the first stop for looking at all of these things in detail, because let's find the low-hanging fruit and treat the things that are treatable. And so starting in that conversation that we're not accusing of anyone, we're trying to get adequate treatment is oftentimes a good way to start that conversation.
Also just, correct me if I'm wrong, but Medicare now both pays for and requires that you do, that your general practitioner does a short screening for cognitive change, so that hopefully what you're talking about, maybe people do tend to be more receptive to their doctor than their grown children for a variety of reasons. And so that is a good place. And as Jared said, being able to take that conversation as maybe there's an infection, maybe there's something we could do to help you, feel better, function better, so on. Yeah.
On that point, so it's Chris from BrainCheck. Thanks for the presentation. We have hundreds and hundreds of providers who assess patients, but we also have hundreds and hundreds of providers who decide that they're not going to do exactly what you just mentioned because they don't have time or they don't have staff. And our math is that it would take approximately 13,000 additional clinicians in the United States to provide these assessments that you just mentioned. Is there any research about getting time and people into the workplace to provide the assessments?
I think that speaks to what Jared was mentioning earlier and to Alyssa's work trying to make sure that we take healthcare professionals. And you want to comment, Chandra?
I just want to say that so much of there's a subtext here. So much of what we know from clinical studies of dementia is based on people who end up in the healthcare system, but the majority of people don't. And so that's why it's so important to get community studies out there and really understanding the scope of the problem and how those symptoms might be different in other circumstances. And I'll say, I've only been working in this area about 10 or 15 years, so relatively new for me. I've been shocked at how little information there is out there about what they call community studies. So I actually think talking about low-hanging fruit, that's the lowest hanging fruit.
Yeah, I think that's the point, is that we want to prevent. In an ideal world, we prevent, we don't cure. And
Well,
we're covering that spectrum.
Yeah. But also understand that the symptoms may be different in different population groups.
Yeah, absolutely, absolutely.
Hi.
Go ahead.
They said you need a plumber.
I'm sorry?
I'm kidding. So, Dr. Augusto from Dr. Augusto from the UT Houston School of Public Health in Austin. A question for Dr. Duarte. That relationship that you found about sleep, did you deep dive in sleep quality or hygiene, or the phases of the sleep has more effects on the brain or the cognition?
That's a great question. So, first part of it, sleep hygiene. So this is like sleep habits, and there's a super strong relationship between a person's sleep hygiene, things like stressing around bed or in bed, phones in bed. Don't do that. Those are things that not everybody understands actually really negatively impact your sleep and can be corrected. So yeah, we found that was a strong relationship. With regard to the specific neural signatures of sleep, we have a larger ongoing study to look exactly at that, but we have some predictions. We have some preliminary data showing some of the variables that are measured during deep stages of sleep, which is where older adults particularly have a less of amount, is important for memory performance. I think that was your questions. Did I do it? Okay.
We're going to take one more, and for those of you on Zoom, we'll be sending you the resources and so on, so you can reach out after. I think we have one more question, and then we'll wrap up after that.
So in addition, is it on? In addition to being a staff member here at UT Austin, I'm also a grown adult caregiver of someone with moderate dementia in my home. But I was curious to know a little bit more. I mean, it makes sense logically from a lay standpoint that there's a link between dementia and heightened mortality. I think you said the number 5 leading cause of death. Or could you say a little bit more though about why or how that might come about?
Before we say that, I do want to tell you it's we are in the U.S., Texas has the second highest rate of death from dementia of any other state. So it is a really pressing problem here. Do you want to comment on some of the things that happen to the body that lead to mortality?
Sure. Yeah. No. So this is a question that we routinely get asked, and so it's important to keep in mind that that deaths in dementia are very rarely, you learn to never say never when it comes to brain, but very rarely due to the actual brain process itself. What you actually see is heightened risk for things that can lead to death. So a big driver is falls. We oftentimes think about walking as something our body does and not a brain thing, but walking is actually an incredibly complex brain activity. And so unsteadiness and falls tends to set off this cycle where you get unsteady, you get distracted while walking, you fall, you break a hip, you end up in the hospital, and then the kind of cycle can go from there. Additional problems include things like changes in swallowing that can lead to aspiration pneumonia, bed sores from lack of mobility, as well as self-neglect in individuals who happen to not have caregivers. And so there's many different paths that can lead to the heightened mortality that we see.
I'm going to also give the last comment to Chandra.
Just on the 1 in 5, the other reason or cause is that people are living longer, and so they have a greater opportunity to develop dementia, and so we need to recognize, but the costs associated with it mean that it's really important to understand. Also, people in different resourced populations may develop earlier or later, but if you live long enough, the chances are pretty high.
Yeah. On that note, this is a really pressing, important issue. I'm very. Well, we're gonna do it. We're gonna do it. I mean, the time is now. If you'd asked me 10 years ago, I've been in this field for 30 years, and if you'd asked me at the start of my career 10 years ago, I would have said it's a pipe dream. We're just going to have to, live with it and figure it out and help the caregivers. I don't think that's true. I think the time is now. I think this is going to happen, and we are going to make the inroads. And it's going to be from people like my colleagues that are moving very rapidly in all of these areas. And we're grateful that we had the opportunity to tell you more about it and actually to learn from each other. There's so much going on this campus. I don't always know what's going on. So thank you for coming today, and hopefully in a few years we'll be reporting back to you on everything great we've done to change the course of things. Thanks again.